Hey everyone, and welcome. We are going to jump right into a topic that, let's be honest, we deal with multiple times a day behind the counter: allergic rhinitis. Think of this as your practical, no nonsense guide to really mastering patient assessment and counseling. Okay, let's set the scene. You know it well. A patient walks up to your counter with that classic trifecta of symptoms: a running nose they can't stop, constant sneezing, and those itchy, watery eyes. So what's our first move? What's our game plan? What are those make or break questions we need to ask to get them on the right track? That's exactly what we're about to unpack. So here's how we're going to break this down, and we'll do it just like a real patient encounter. First, we'll cover assessing the patient. Then we'll jump into the go-to first-line therapies. After that, we'll talk about what to do when that's not quite cutting it. Then we'll really zero in on our key counseling points and side effects, which is where we really shine. And we'll wrap up by touching on a few special populations. Sound good? Let's dive in. All right, first up, assessing the patient. This is all about going beyond just the sneeze. It's about putting on our detective hats and getting a really solid clinical history right there at the counter. So what do we really need to find out? Let's get into the specifics. Are we talking mainly about congestion, or is it that maddening itch that's driving them crazy? Are there eyes involved? And what's the pattern here? Does this hit them every spring like clockwork, or is it a year-round battle? We need to ask about triggers too: pollen, pets, dust. And don't forget to check for things like asthma and take a quick look at their medication history. Drugs like ACE inhibitors can sometimes mimic these symptoms. And maybe the most important question of all: so what have you already tried? And that brings us to one of the biggest challenges we face. Is this actually allergies, or is it just a common cold? Well, here are the key tells. With allergic rhinitis, the number one clue is the itch: itchy eyes, itchy nose, even an itchy palate. A quick look, if you could, would show a pale, almost bluish nasal mucosa. A cold, on the other hand, is usually a one-and-done episode lasting about a week and often comes with a sore throat or fever. And the nasal mucosa? Usually bright red. Okay, so we've got our assessment down. Now let's move into section 2, first-line therapy. This is all about the evidence-based foundation, the starting point for getting our patients some real relief. And let's be crystal clear about this. For anyone with moderate to severe symptoms, intranasal corticosteroids, or INCs, are the absolute gold standard. They are without a doubt more effective than oral antihistamines, especially when it comes to tackling that number one complaint: nasal congestion. Now, when we do talk about antihistamines, it is truly a tale of two different generations. The first-generation options, like diphenhydramine, well, they come with a ton of baggage, heavy sedation, and all those annoying anticholinergic effects like dry mouth. But here's the real kicker: they can impair a person's attention and memory without them even feeling tired. That's why the second-generation agents, your loratadines, your cetirizines, are always the preferred choice. They're way less sedating, and they don't mess with performance. Okay, so what about that patient who comes back and says, "Hey, this nasal spray you recommended, it's just not enough"? That's when we need to know how to escalate their care. Luckily, we've got a few more tools in our toolkit. For really bad nasal blockage, an oral decongestant can be a good add-on, but you've got to be careful with patients who have high blood pressure. For short-term, severe congestion, an intranasal decongestant can work wonders. If your patient also has asthma, that's a perfect time to think about montelukast. And for those who are still struggling on an INCS alone, a commendation spray like azolastine with fluticasone can be a real game changer. Now, speaking of those intranasal decongestants, we have to talk about this: rhinitis medicamentosa. This is that classic rebound congestion, a vicious cycle where a patient overuses a sprayer like oxymetazoline, their congestion gets worse when they stop, so they spray again, and they get trapped. So this leads us to an absolutely critical counseling pearl. It's non-negotiable. You have to tell your patients to limit the use of these sprays to a maximum of 3 to 5 days, period. That is the key to preventing that rebound effect and keeping them out of trouble. And this brings us to the part of the job where we can have the biggest impact: our key counseling points and managing side effects. This is how we boost adherence, keep patients safe, and actually improve their outcomes. So let's talk about the number one complaint with nasal sprays: nosebleeds. And it's almost always due to bad technique. We can fix this. Walk them through it. First, prime the bottle. Gently blow your nose. Now here are the two most important parts. Tell them to look down at their toes, and then use the opposite hand for each nostril. This forces them to aim the spray away from the septum and towards the ear on that same side. That one little tip makes all the difference.
And not all nasal sprays feel the same to the patient. Knowing these little differences helps us personalize our recommendations. For example, fluticasone furoate has a really low spray volume, which makes it a great choice for kids who hate the feeling of a lot of liquid. Mometasone is unscented, and for patients who truly can't stand sprays, remember that budesonide also comes in a dry powder inhaler. These details matter.
I want to circle back to those first-generation antihistamines for just a second, because this quote right here is so incredibly important. Patients who are unaware of sedation may be impaired with respect to attention, memory, vigilance, and speed. That's the hidden danger we have to counsel on. It's not just about feeling drowsy. It's about a real cognitive impairment that can affect their ability to drive, work, or learn safely. All right, let's head into our final section, special populations. This is where we need to fine-tune our advice for kids and for patients who are pregnant or breastfeeding. When you're talking to a parent about their child's cold or allergy symptoms, there is one number I want you to burn into your memory: 6. We have to be really clear that oral cough and cold products that contain decongestants are not recommended for any child under 6 years of age. This is a huge safety point. Okay, now for pregnancy. This requires a careful step-by-step approach. The first line is always the simplest: saline nasal sprays. If that's not enough, intranasal corticosteroids are the next best choice because so little gets into the bloodstream. Budesonide has the most safety data behind it, making it a comfortable choice. And if an antihistamine is absolutely necessary, cetirizine and loratadine are considered the safest options. Now, on the flip side, what should we be cautious about? Well, oral decongestants should definitely be avoided during the first trimester. And when it comes to immunotherapy or allergy shots, you should never start it during pregnancy. However, if a patient is already on it and stable before she becomes pregnant, she can usually continue. And for our breastfeeding moms, the advice is a little more straightforward, which is great. Both the less sedating second-generation antihistamines and the intranasal corticosteroids are generally considered safe to use. And that brings us to a final thought to leave you with. We're now seeing treatments like sublingual immunotherapy, those under-the-tongue tablets, becoming available over the counter. So the question for us is, how is our role in managing the full spectrum of allergies changing? How do we position ourselves to be the go-to experts for our patients in this evolving landscape? It's definitely something to think about. Thanks so much for tuning in.